Today we will be talking about approach to clubbing. So what is clubbing? In simple terms, clubbing is the bulbous enlargement of fingertips along with an increasing anterior-posterior as well as lateral curvature of the nails. So you see normal fingers like this, and your anterior-posterior, this thing will become like a concavity will become convex. Normal concave, this thing will become convex and it will become clubbed. And there is a difference from koilonychia. What is the definition of clubbing? Clubbing is defined as bulbous enlargement of terminal phalange. This is terminal phalange. This is terminal phalange due to proliferation of connective tissue between fingernail and the bone. So this part will have proliferation and it will become convex. There will be bulbous enlargement. What is the importance of clubbing? The presence of clubbing in a person almost always indicates presence of serious underlying infection. So there might be malignancy, there might be. So we have to form the soft tissue, right? So there might be a chronic pus, like in lung abscess, or there might be a chronic pathology like cancer. But rarely it can be an innocent bystander, like for example, congenital clubbing. Sometimes in traumatic clubbing. So, it is Hippocrates defined it, described it. So it is called. He is also the father of medicine as we know it. So what is pathology? Obviously, due to the hypertrophy of the tissue occurs due to the interstitial edema and dilatation of arteries and capillaries. Right? The nail bed capillaries are hypertrophied and dilated. So how does we talked? So what is a firstly you must remember about this clubbing, the causes of clubbing. So this chapter is approach to club. So we must remember the causes of clubbing. So I'll detail. So it is the mnemonic goes CLUBBING. For firstly, C denotes causes of. We can all assume. Clubbing is mainly caused due to hypoxia, lack of oxygen, which leads to hypertrophy and proliferation of anoxemia will lead to vasodilatation and proliferation of subcutaneous tissue of nail bed. So let us do the mnemonic first. C for cyanotic heart disease, right? L for lung abscess, okay, and lung cancer, okay. B for bronchiectasis. B for benign mesothelioma. It is again a form of lung cancer, though benign. Okay, and biliary cirrhosis. I for infective endocarditis and inflammatory. Okay. N for again some neurogenic tumors, and G for chronic GI diarrhea like inflammatory bowel disease. So I will repeat. C for congenital heart disease. Mainly that is cyanotic, not in acyanotic. Only when you have hypoxia, it will lead to cyanosis. Sorry, yes. Then you have L for lung cancer and lung abscess, right? U for ulcerative colitis. B for biliary cirrhosis and bronchiectasis. I for infective endocarditis, N for neurogenic tumors, and G for chronic GI diseases. So these are the common causes. Now it will again discuss it. Pathogenesis hypoxemia is a major cause. So it leads to vasodilatation and proliferation of subcutaneous tissue of nail bed. So you will have increased capillary permeability and this part will become edematous. So this is described here also. So how to examine? Basically, normally you will have the concavity, and you can see this thing will become convex once you have the bulbous enlargement. So you will have a clubbed finger. So this can be done by formally doing a test, but you can just inspect by checking for obliteration. You can check the shared diamond shaped gap between the nails. gap is reduced or obliterated in clubbing. So this is called a Shamroth window test. So basically what is happening here, the window which is normal gets obliterated in clubbing. Right? And diamond shape is not a clubbing. This is commonly asked question. What are the grades of clubbing? The softening of firstly, basically what you have to do is make the palpate, firstly palpate the nail bed. So you soften the nail. So you will detect softening. Then you will have obliteration of the angle, which is seen in the window test. Then you have increased AP curvature. Then finally your phalange will become like a drumstick due to increased hypertrophy, and finally it will extend to the wrist joint also. That is called a hypertrophic arthropathy. It is important. This is tested on exam. So firstly you will have softening of nail bed due to vasodilatation. Then you will obliteration of a nicodermal angle. It is also equivalent to Renishaw test. The angle is blunted. Then you will notice a visible increase in curvature. It is visible on the examination. Then you will have terminal enlargement, bulbous enlargement, and finally you will have wrist inflammation as well, also known as hypertrophic osteoarthropathy. It is commonly seen in lung cancers also. So grading clubbing has no prognostic significance, but it is for what is the how is it increasing, right? Now it must be remembered that it has no prognostic appearance, so it may not be present in advanced malignancy. It is also a function of how chronic, for example, something appears acutely. So obviously the clubbing is likely to be lesser because hypoxia, the vasodilatation takes time. Severe clubbing may be present even in case of congenital or traumatic clubbing. So as I said, if something is chronic, it is most likely to be clubbing is likely to be there. Trauma can also lead to clubbing because of local disturbance in vasodilatation of the vessels. Mostly, there should be any systemic disease will affect both hands, both legs. So any systemic illness, for example, respiratory, cardiovascular, hepatobiliary, and GI, and uncommonly endocrine, congenital, traumatic would be caused bilateral clubbing. So, what are the cardiac causes? Anything cardiac which leads to hypoxia. So, you have Fallot's tetralogy and Eisenmenger syndrome. What is Fallot's tetralogy? It's a right to left shunt. Right? Normally, what happens is the oxygen goes from right atrium, right ventricle, goes through purification to lungs, and then goes into the left ventricle from where it is pumped out. Now here in Fallot's, what happens is you will have ventricular septal defect and pulmonary stenosis. So your lungs, this thing is not going for filtration properly in the pulmonary artery, but indirectly it is going to the left ventricle without filtering. So this is Fallot's tetralogy. Eisenmenger syndrome. Here the normal shunts for normally ventricular septal defect or atrial septal defect, where the left ventricle sometimes gives blood to right ventricle because left ventricle has high pressure, right? So, but gradually over a period of time, what will happen? The pressure in right ventricle will rise. Why? Because the right ventricle is not that much compliant. So right ventricle pressure will rise and it will go pump back into the left ventricle. Now we know that right ventricle and right atria the oxygen is low. So once right ventricle pressure will exceed the left ventricle, it will be called Eisenmenger syndrome. So even acyanotic heart disease, that is diseases which were congenital heart disease, which were acyanotic start like atrial septal defect, ventricular septal defect, they will also go on to become cyanotic with age. Then bacterial endocarditis and atrial myxoma. So bacterial endocarditis, as I talked, chronic suppuration can also lead to vasodilatation and left atrial myxoma also. Pulmonary causes, as I told, lung cancer is a major cause. Then lung abscess, again it's a chronic cause and suppurative cause. Bronchiectasis, similar etiology. Rarely caseous TB or you have pulmonary AV communication and mesothelioma also. So basically AV communication similar to the right-left shunt. TB is suppurative, showing lung abscess. Any cancer, bronchogenic carcinoma can lead to pleural mesothelioma. It's a benign mesothelioma. Generally, peripheral plaques are seen. What are the GIT causes? So you have to investigate for cardiac causes and lung causes. How do? You take a saturation by a pulse oximetry. So once I see clubbing, I do a saturation. So you will have low pulse oximetry saturation, or you will have chronic fevers like lung abscess, etc., or bacterial endocarditis. Then what are the GIT causes? Ulcerative colitis, Crohn's disease, biliary cirrhosis. So what the patient will have? Chronic diarrhea, bloody diarrhea here, and biliary cirrhosis. Here you will have direct conjugated hyperbilirubinemia. Okay, your eyes will be, there will be deep pictures. So GI, it comes to hepatic cause. Main cause is biliary cirrhosis. Not every cirrhosis will lead to clubbing. Biliary cirrhosis is a unique feature. Other causes, as I told, that congenital, familial, genetic, and sometimes thyroid diseases can also cause, but these are relatively rare, and primary patchy dermoperiosteotitis. Bronchiectasis, as I told, it is a chronic suppuration. It will lead to clubbing, low-grade fever, lot of cough, and that. Lung abscess, again chronic suppuration. The clubbing can start as early as 2 weeks. Here you will high-grade fever, chills, toxemia. Any chronic suppuration in body, lung abscess, bacterial endocarditis, that may lead to clubbing. Empyema thoracis, again you have a lot of pus in the layers of pleura. Here also, cancer can lead to clubbing via increased growth factors. So this is an important cause. Now, very important, clubbing can precede the symptoms of malignancy by weeks or months. So it's a paraneoplastic syndrome. This is very important. It is not only due to hypoxia, but it is due to growth factors. In congenital heart diseases, cyanotic heart diseases, it is due to hypoxia. Or even in interstitial lung diseases, the clubbing is due to hypoxia. But here, it is due to growth factors. So this is very important. Pancoast tumor, you have upper lobe of lung is involved with local infiltration of tumor into various structure. So what will happen? It will go into this part. It will obstruct the supplies. In addition, you will have paraneoplastic syndromes also. So a combination of hypoxia by blocking the supply as well as the growth factors. So clubbing is universally present in Pancoast tumor. Bacterial endocarditis, as I already talked, here you will have high-grade fever, high to low-grade fever, pallor, jaundice, hematuria, splenomegaly, splinter hemorrhages, and ocular nodes in nails. So it is when the walls get infected. Thyroid arthropathy. So apart from clubbing, other features of hyperthyroidism will be there. You know, right? Like staring of eyes, tremor of fingers, frequent loose stools. Patchy dermoperiostosis, it's a primary form of clubbing, like hypertrophied skin on dorsal hands. Now, unilateral clubbing, generally, as we were talking, it is systemic, but sometimes it can be unilateral once because there will be a local block. For example, if you have cervical rape, you have Pancoast tumor, then you have aneurysm of subclavian artery. Again, you are seeing something around the great vessels and the upper part of thorax, pre-subclavian coarctation of aorta, or AV fistula, right? The artery-venous communication is impaired. There is a fistula formation, just like a shunt. That is a man-made shunt. Differential clubbing, once you have clubbing only in upper limbs or in lower limbs, that can happen if there is limited obstruction in the upper limbs, chronic obstruction of veins, or you have chronic thrombophlebitis, right? Your veins are become swollen, so it can happen. So differential clubbing in upper limbs might be due to upper limb involvement, or lower limb might be due to lower limb involvement. It can be seen in patent arterioartosis, patent ductus arteriosus with reversal of shunt, as I was talking. Here you have the blood flowing through abdominal aorta. So here what is happening is till you have thoracic aorta, ascending and thoracic aorta, it is not affected, but the blood going to the abdominal part of the aorta that is down, that is affected. So how is it become? It can become hypoxia by patent ductus arteriosus persisting with the reversal of shunt, or if you have an abdominal aortic aneurysm, right? You have a chronic suppression down, so there you will have a differential club. Hypertrophic osteoarthropathy, as I told initially, it will start at terminal bulbous, then it will go on to involve all the joints and the wrist also, right? Long bones of hand and feet also. Classically seen in Pancoast tumor, but also in severe cases of lung disease and CLR. What are bone changes in HPA? So this is what happens in your periosteum. The bone thing will become new bone formation. So you will have a periosteal new bone formation, also known as sunrise appearance on X-ray, and symmetric. It will be symmetric. Similar changes are seen in chronic osteomyelitis though, but this is very common in hypertrophic pulmonary osteoarthropathy. So what are conditions that are clogging and cyanosis? So anything hypoxic which is causing clogging is this thing. So you have Fallot tetralogy, right? Eisenmenger syndrome. Then you have interstitial lung disease. All these are chronic hypoxia, so clubbing and cyanosis. There is no treatment for clubbing. You have to determine causes. You have to look for hypoxia, do a saturation, ask for if there are GI disorders, ask if you have chronic diarrhea, ask if the patient has chronic fevers, for example, in lung abscess, in bacterial endocarditis, right? Ask is there an history of trauma. Take, you should palpate all arteries and all arteries, radial artery, if there is any difference that can cause a local cause of club. So if you treat these causes, you can reverse the condition. Prognosis, as I said, it will depend upon the cause you are treating. If you are able to collect the cyanotic artery, it will go on its own. If you treat lung abscess, if you treat endocarditis, it will go on its own. Right? So this is an important distinction too. If you treat GI inflammatory bowel disease, it will go. Okay. So I think I have made it clear. So the approach will depend upon remembering the causes. I'll again reiterate the causes. C. So it's mnemonic is in name. C for cyanotic heart disease. So you have Fallot tetralogy or Eisenmengerization of a cyanotic verse. So these C for this thing. L for lung abscess, lung carcinoma. U for ulcerative colitis, which is chronic diarrhea. B for bronchogenic carcinoma, and biliary cirrhosis and bronchiectasis. I for infective endocarditis. N for neurogenic tumors. Okay. And G for chronic GI diseases. So roughly you must remember the causes and mnemonics are once you are sure about the etiology. And these are the lung, heart, and GI systems are the major systems you are looking at, but sometimes it can happen in thyroid disease as well. Okay, thank you.